Greetings everyone. Welcome to the 254th session of the online Optom learning series OOLS. And for today's session, we have with us Dr. Alison Ng. Dr. Alison is a lecturer at the School of Optometry and Vision Sciences at Cardiff University in the UK. She's an optometrist with over a decade of research and clinical work experience involved in doing a lot of clinical research trials of medical devices, drugs, natural health products, where she was associated with the Center for Ocular Research and Education at the University of Waterloo. Her research areas are very much concentrated, I would say, in the ocular surface response to the environment, the use of cosmetics, contact lenses, dry eye, nutrition, and also a little bit work on the corneal neuropathic pain. She's a fellow of the American Academy of Optometry, and she's also a member of the British Council Contact Lens Association. So she's going to talk to us. I think when we were discussing earlier, we said that this is going to be a very unique topic about how to take care of the periocular region, and she's going to share insight of this topic and take us through about how can we examine and how can we look at it and how can we advise our patients. So thank you so much, Dr. Alison, for joining us today on this afternoon, and I'm going to leave the screen time to you, please.
Thank you so much for the invitation to speak again. It's very nice to share something that's a topic that's quite close to my heart. And something that might be a little bit different to some of the other topics that's typically offered in this learning series. So thank you for taking a risk on me and sharing this topic. But I think it's quite important that for all of our optometry colleagues to just have an understanding about some of the things we're going to be talking about, because the periocular skin does form a large part of what we look at as optometrists. It might not be the thing that we focus on predominantly, but hopefully today you'll leave with some little tips and tricks that you might find useful to implement in your clinical practice right away. So I'm just going to start by giving you my disclosures first of all. So in the past 12 months, I have received honoraria from various companies here, and I'm also a consultant for Johnson & Johnson Vision, aside from my additional work at Cardiff University. So today we're going to have 3 specific learning objectives. So what we want to understand at the end of today's session is the structure and function of periocular skin. Hopefully you'll have an understanding of some of the common signs and symptoms that present in the periocular skin region that your patients might present with. And then also hopefully leave with an understanding how to advise your patients on how to maintain a healthy periocular skin barrier. And this is quite important because skin is the largest organ of the human body. And if we think about kind of the periocular, the eye area, it is quite a small proportion relative to the rest of the body. But part of today's discussion will really come around kind of the importance of maintaining that healthy skin so that your patients look well and they are able to see well as well, because the health of that skin is important to how the eyelid and the eye functions. So we have a classic scenario where your patient comes in and sits in the chair, and I think we've all had a patient like this at some point in our careers, and they'll say that my eyes are feeling irritated, itchy or sore. And when a patient presents with this sort of problem, what's the first thing that comes to your mind? Is it the irritation that's coming from the level of the ocular surface? Or is it coming from the level of the eyelid or the eyelashes? Or is it even coming from beyond the immediate eyelid and eyelashes? And I think what's as optometrists, I think that I'd like to think that we all would be very good in taking a thorough history to determine where the source of the problem is. And of course, our examination will probably encompass all of these 3 elements: the ocular surface, the lids and lashes, and a little bit further around that skin area. And it might even involve looking beyond that immediate eye itself. And we'll talk about this a little bit later on. But unfortunately, patients aren't equipped with the best vocabulary when it comes to talking about irritation or discomfort of the eye. And what they're referring to when they talk about irritation or discomfort might not be retained to the area of the ocular surface. So really today's talk is really going to encourage you to focus on the wider periocular region as well when you're talking to your patients and managing their overall eye health. And this can start from all the way up from the eyebrow and all the way down to the lower eyelid fold and all those compartments in between. So this little graphic, I'm sure you're all going to be pretty familiar with as clinicians. We have the overall eye drawn here and all the different eye structures. But if we break it down a little bit more closely to the areas that we're going to be really interested in talking about today, and that's the eyelids and the tear film that's in between here. And of course, the eyelids themselves are made up of lots of different glands and lots of different types of tissue. And the eyelid margin itself measures about 2 millimeters thick. And what we have is two different types of tissue. We have what I'm going to call the dry side, so the skin side, the epidermis side. And then on the other side, we have the conjunctiva, which is the moist mucous tissue side of things. And we have that transition from the dry skin all the way through to the more mucous membrane side, and that transition at the mucocutaneous junction. And like I said earlier on, this area of the body is very, very small, but it's richly innervated, which means that what happens is that patients might have a very small problem, but it can mean that it's such a sensitive area that the patient gets a lot of discomfort relative to perhaps other parts of the body. The other thing about this part of the body is that it does receive a lot of daily manipulation. So what I mean by that is here we have the diagram here where we've got different points where different eye makeup products might be applied. So your patients might be somebody that uses a lot of eye cosmetics or uses some eye cosmetics, and that will have an impact on both the tear film side and also on the skin side because they're applying the product to the skin side, but also contamination of those cosmetic products end up contaminating the tear film and can have some downstream effects from there. But also if you think about kind of the patients who might not be using eye cosmetics, we then have the fact that, patients will touch their eyes every day, whether they're applying contact lenses. And if they're not a contact lens wearer, we typically touch our eyes or rub our eyes on a day-to-day basis. And this can be a seasonal thing as well. So for example, here in the UK, it is peak spring, it is peak allergy season. So a lot of my patients are coming in, rubbing their eyes quite a lot because there's a lot of seasonal allergens for them. And because they get an allergic response on the ocular surface, they are still having to use that eyelid skin to close and rub their eye to get some form of discomfort. And all this tugging and pulling can cause some changes to the skin side. So now that I've set the scene a little bit, I just want to talk a bit more about skin itself and skin biology. So periorbital skin is, you've probably heard this before, is the thinnest skin compared to most other parts of the body. So if we think about the skin on the palms of our hands or the skin that's on our face, on our legs or on our feet, it is really the thinnest skin compared to other parts of the body. But the eyelid itself is quite unique. That skin needs to be soft and it needs to be smooth and pliable so that it can move up and down every single day to support blinking. And if you remember the statistics about blinks, we blink on average about 16,000 times a day. So that is a lot of lid movement up and down every single day. Because of the thinness of this skin, the eyelid itself, the eyelid skin is more susceptible to irritation. And this includes things like contact dermatitis and atopic dermatitis as well. And part of this is because there's less or fewer surface lipids on the eyelid region and on the periocular skin compared to other parts of the face, such as the tip of the nose. And I'm going to talk a bit about lipids a little bit later on and the role that it plays in maintaining skin health. But if we take a step back more broadly, we think about what role does skin have? What is its ultimate purpose? And it's multifactorial, it does lots of different things. So skin itself is the biggest barrier to the outside world. It's our protective shield, so to speak. So it stops things getting in and it stops things from leaving as well. Aside from that, it also regulates our body temperature. which you might remember from biology from years ago. We have sweat glands, our blood vessels will dilate and constrict, and so on and so forth. Our skin also helps regulate water contact within our body as well. It's also a sensory organ, so it allows us to touch different things and be part of the world and understand the dangers. So you're not putting your hand on a warm surface that could end up burning your skin, for example. And like I said, skin itself also does protect from different organisms or microorganisms in the environment, and also mechanical injuries as well. So if you cut yourself, it's got ways to repair. Other external substances, so things like I can talk about cosmetics, but it can be allergens or pollutants in the atmosphere. And of course, we live in a world where we do have a sun and radiation, so it also gives us protection from UV radiation as well. And we'll talk about UV radiation in today's talk as well, and the importance that skin has in that. So I'm going to dig a bit deeper into skin biology a little bit more, because this will play quite an important foundation into kind of the other things I'll talk about later. But overall, we have three main layers of the skin. We have the epidermis, the dermis, and the hypodermis, and each layer plays an important role. What is not on this particular picture here are things like hair follicles, sweat glands, and sebaceous glands, and they're glands and biological features that are vital for the overall function of the skin, but they're just not on this particular image here. So the very, very top layer that's exposed to the world is the epidermis, and this provides us that physical barrier. And I'll talk quite a bit more about the epidermis on the next slide. But then we have the dermis rather, which is probably the chunkiest layer here in most parts of the body. And it's a network of structural proteins. So we have collagen and elastin that are bound together by a gel-like substance which contains hyaluronic acid. And this hyaluronic acid binds a large volume of water, and effectively the dermis is what really makes up the volume of our skin. And within the dermis, we can also see we have blood vessels here as well, and these dilate and constrict to manage our body temperature, and it also helps transport different nutrients. And within this layer, we also have cells like fibroblasts and mast cells, and these also respond then to things like inflammation and wound healing. Within the dermis, we also would normally see in a different diagram, if I just perhaps selected a different one, and we'd also normally see things like hair follicles, sebaceous glands, and sweat glands as well. And then the very, very bottom layer, then we have the hypodermis, and this is the innermost layer which contains the fat and connective tissue. And typically the eyelids themselves don't have an awful lot of subcutaneous fat. Actually, some reports say there's no subcutaneous fat at all, and then there are some reports that amongst Asians, their eyelids have a little bit more subcutaneous fat. But if we think about the epidermis, because this is kind of be our biggest barrier and part of the skin that holds perhaps some of the biggest functions in terms of overall skin health. Like I said, it stops things from getting in, so things like bacteria and soil, and it stops things from leaving as well, so things like your water and your electrolytes. So it really does help maintain skin hydration, and also is that physical barrier. It's also got a big role in UV protection and protection from oxidative damage as well. And even the epidermis itself is made up of more layers within it as well. And one particular layer that I'm going to focus on the next slide is the stratum corneum, this very, very top layer here. And this stratum corneum is imperative in maintaining the epidermal permeability barrier. And it really does play a huge role in maintaining skin hydration and protection. But also as part of that as well, it also hosts the skin microbiome as well. So because it's that very outer layer, we have natural bacteria and yeasts that live on our skin as they do on all parts of our body. The stratum corneum is often referred to as kind of a bricks and mortar kind of structure, where our bricks are our corneocytes, which are effectively dead keratinocytes. And then the mortar, the things that fills in between all of these corneocytes, are lamellolipids. And I'm going to talk a bit more about lipids in the following slides to come. But effectively, what happens is at the very, very basal layer of the of this epidermis, we have stem cells, and these differentiate into keratinocytes. And as time goes on, about sort of 14 days or so, they differentiate and they move upwards, and then they become these corneocytes on the very, very outer layer. And as these keratinocytes differentiate and they move the way upwards, they change shape. So they flatten out, they die, they lose water. But also as they move upwards, they release lipids. And these lipids that they're releasing is making that mortar in that very, very upper layer of the stratum corneum. And the reason why these stem cells differentiate and they move upwards is because that very, very top layer, the stratum cornea, those corneocytes will eventually shed and die and be replaced by these newer ones that come through and replace it. Now, each of these little bricks, these corneocytes here, is made up of keratin. And that really gives the stratum corneum its toughness and its structure. And each of these cells are surrounded by lipids, and these lipids contain ceramides, which is something you might have heard if you buy any moisturizers in the store. Also contains fatty acids and cholesterols. But within each cell itself as well, you also have something called natural moisturizing factor. And these natural moisturizing factors is made up of different things like amino acids, urea, and lactate. And what this natural moisturizing factor does is it attracts water into the corneocytes to help these cells retain its hydration as well. So this is really kind of critical in terms of maintaining overall skin barrier health and the overall functionality of the skin barrier. And ideally, what we want in a healthy skin barrier are these nice plump corneocytes, so these bricks that are nice and juicy and big. They're sitting close to one another with very few gaps, and if there are any gaps, there's the lipids filling it in to make a nice, smooth, strong barrier. Now, the overall skin cycle takes about 28 to 30 days, but if we have dry skin, it can be disturbed, so it can be shorter or longer, depending on the condition that we're talking about. Now, we've talked about a skin barrier, but why is a good skin barrier important? It's important because it, like I said before, and multiple times now, it's given us protection from the external world, and this contains this includes anything like irritants. It can be chemicals, it can be allergens, it can be anything whatsoever. But a weak skin barrier means that it's losing hydration, and a weak skin barrier is more susceptible to dehydration. And we can measure skin barrier functionality and skin barrier health through a metric called the transepidermal water loss. And what this is measuring is how much water is evaporating from the skin surface. And for patients who have a poor skin barrier, or in studies where they are trying to test for transepidermal water loss, a higher value typically represents a poor skin barrier or poor skin functionality. And what we can then start to see is things like cracking, dry, flaky skin, and it'll exacerbate things like fine lines and wrinkles for some patients. But it's really important to keep maintaining this barrier, because otherwise we end up in this vicious cycle, so to speak. So this is a really cute little graphic, which I very much like, because I think it really highlights this cycle. It's a bit like dry eye disease. You end up in this vicious cycle that just kind of exacerbates the skin conditions. So if we start off with skin that is dehydrated and exacerbated by dehydration, what that ultimately leads to is water loss. But it also means there's increased permeability of stresses and allergens, which then leads to inflammation. So in the area of the dermis, we get in a cytokine response, we get in the mast cells coming in, so the skin becomes more red, more inflamed, more angry. And as a result of that exacerbates the dehydration cycle, the water loss, the antonyms are getting in again, and again that inflammatory barrier that we see, a red, irritated skin response, just gets further and further exacerbated. So I said that lipids form a very important part of skin biology, and lipids play a really important role at the tear film level and the skin level. I'm sure you're all very familiar with the structure of the tear film. And I think it's really nice that there are so many parallels that we can draw between dry eyes and dry skin. So I think it really helps us as optometrists really convey some of the things that we see and be able to communicate some of this stuff to our patients. So, for example, if we think about kind of the lipid bilayer of the tear film, it is the thinnest element of the overall human tear film. But we know that without it, tear film evaporation increases fourfold, and then that leads onto a whole cascade of dry eye problems. And it's not dissimilar when we think about the skin biology itself. Without a healthy amount of lipids, that mortar in between all the cells, the moisture is not being kept in, and the barrier in the dirt is not being kept out as well. And it's going to increase inflammation at a skin level. And healthy skin contains about 30% water, but in order for that to be retained, we need to have all those lipids in within the cells and within the stratum corneum structure, those lamellar lipids that I spoke about. But what's really, really interesting is some studies which are looking at whether there's a connection between dry skin and dry eyes. And this is one paper that looked at a very small sample of patients, really. It's about 50 patients. 25 of them had dry eye symptoms, and then 25 didn't have any dry eye symptoms. And what they found was there was a strong connection between those who had dry eyes and dry skin. And how they did this was they measured the amount of sebum, so that's kind of the oils that are produced by our sebaceous glands, in the cheek and at the forehead. And what they found was the patients who had dry eyes had lower amounts of sebum in the cheek and the forehead compared to those who didn't have dry eyes. So the subjects with dry facial skin also had drier eyes. And this can translate into any number of kind of presentations for patients when they have dry skin. It can mean sometimes the skin just doesn't feel as elastic, or it is not as strong or as plump. But I think overall, if we think about the number of patients we see on a day-to-day basis that have dry eye disease, I think it's a good also opportunity for us to speak to our patients about any dry skin concerns that they have in conjunction with their dry eye, or they might even tell you anyway, about the irritation that they have, a skin side as well as ocular surface side. So we get a variation of lipid across the body, and the amount of lipid we see on the surface of the skin across the body, but we also get regional variations across the face as well. And on the eyelids themselves, if you compare it to healthy individuals anyway, if you compare the amount of lipid on the eyelids compared to the cheek, there's almost 5 times less surface lipid on the eyelids, and if we compare it to the tip of the nose, there's 10 times less surface lipid. And that's probably not a surprise to most of us, if most of us are quite versed in talking about different, or we're just very much aware of kind of skin and how patients describe their skin. We're talking something about the oily T-zone as well that some patients have. So some of these statistics might not surprise you too much, but for some patients who have, dry skin on the cheeks, for example, it might be that surprise where, you think, okay, well, I didn't think cheeks would have that much more oil compared to eyelids, but the eyelids have even less oils compared to the cheeks. And the reason why there's such a big variation across the face is because it's believed that the sebaceous glands on the eyelids themselves are just smaller and functionally poor compared to the cheeks and of the nose. And this is where I get to talk about sebaceous glands a little bit more as well, and what these sebaceous glands produce and why that's important. So these sebaceous glands that we have in our skin secrete sebum. And sebum itself has a whole host of different things that it does, which is highly important to maintaining skin health. So sebum itself actually provides you a little bit of photoprotection, in addition to having some assistance in terms of managing antimicrobial activity. And there's also antioxidant properties that it maintains as well. And as a result of all of these things, it helps modulate inflammatory activity. And sebum itself contains mostly oils and fats, so triglycerides, fatty acids, wax esters, squalene, and vitamin E. And it's that vitamin E which is the antioxidant in sebum. And this antioxidant, this vitamin E, it protects the skin surface lipids from undergoing lipid peroxidation. And that can be quite harmful. That oxidative process can be quite harmful, and this is caused by oftentimes UV radiation itself, and also gives us protection from air pollutants and also some chemicals as well. So it's really important to think that these regional variations of sebum on our face does exist. And if you think about kind of how much less surface lipid sebum that we have around the eyelids, and this translates to the periocular skin region, this means that this part of the body could need a little bit more care and attention compared to some other parts of the, it deserves just as much care and attention compared to other parts of our face. Now, this is a slide about aging skin, because unfortunately, as we get older, as with lots of other skin, other health conditions, our skin also does change and can take a toll as well. When we're first born, infant skin isn't perfect, so it takes a little while for it to ramp up to full skin integrity until we become a fully developed adult. Unfortunately, once we continue to mature, once we get to about our 40s, the skin undergoes changes again. Generally, as we're old, we lose collagen and elasticity, so the dermis changes quite a lot, and so it loses volume. And as a result, our skin can become more thin and more fragile. As we get older as well, we generally produce less sebum, and those natural moisturising factors within those corneal sites, we just generally produce a little less of that. And as a result of that, as we get older, our skin can become more dry and more prone to cracking or splitting. And it's believed that basically for most people over the age of 60, they'll be undergoing some disruption of the skin barrier somewhere within their body. Okay, and then as a result of that, skin, like I said, becomes thinner, and then that causes compromises as well in terms of maintaining overall skin health and overall skin integrity. So if we think about kind of a summary slide here in terms of why we should think about periocular skin to be a little bit more different to the average skin, perhaps in other parts of our body. Skin itself around the eye is generally thinner. It does turn around a lot more quickly compared to other parts of our body. And as a result as well of some of these factors, we have less oil as well compared to other parts of the body on the eyelids. And those sebaceous glands are morphologically quite different as well. They're smaller and we have fewer of them. But what does all of this mean? It does mean that overall, the periocular skin region can be more prone to dryness and dehydration. And as a result of dryness and dehydration, it can lead to it being a more susceptible area to developing irritation, contact dermatitis, and atopic dermatitis. For some of our patients who might think of this from a purely cosmetic perspective, a loss of moisture can cause the skin to appear more dry and less smooth, and this can make fine lines appear more visible. So if we think about this in the analogy of balloons, skin that is full of moisture would be plump, so we've got a nice full balloon here. But once you start losing moisture, that plumpness dissipates, and you'll start to see the development of these fine lines on my little balloon analogy here. So if you're not thinking about this from a health perspective, it does play onto a purely cosmetic perspective as well. So basically, what I really want to hone in here is periocular skin really does deserve appropriate care and attention, and not all of us as clinicians, and not all of us even as when we're on the other side as patients, perhaps think about this on a day-to-day basis. So what can exacerbate or cause dry periocular skin? And this is a list, a summary list that you'll see quite often cited in terms of what can exacerbate dry skin around the eyes. One of the common factors is weather, and particularly extreme weather conditions. So if it's very cold or very hot, if it's very windy or it's very sunny. Relative humidity, so this is kind of the environment that you're in. If it's very low humidity conditions that we typically see in the winter times, that can exacerbate dry periocular skin. Is really well known, particularly for our patients who are very eczema prone. Washing with hot water or being around hot water conditions can exacerbate and dry up periocular skin, in addition to pollution, which can increase the irritation potential to our skin. I talked about aging earlier a few slides ago. As we get older, we just make fewer ceramides and some of those fats and oils and lipids that we need to maintain the stratum corneum. And also we think about different products that patients might put on or around their eyes or even in their eyes. So things like eye drops can also exacerbate dry periocular skin. Some of us here who regularly see patients who are on, for example, long-term glaucoma treatments and using lots of different drops, and these drops might be preserved. Some of the preservatives can exacerbate dryness around the skin, but sometimes the drugs themselves can also cause localized irritation to the skin. And then last of all, we also have allergens as well, and this can exacerbate some of the signs that we see around the periocular skin. But if you look at this long list overall, you probably see there's quite a bit of a parallel between what exacerbates dry eye symptoms and along with what can exacerbate dry periocular skin. Now, there are some things which are not purely dry periocular skin. And I'm talking about skin conditions, things like your contact dermatitis, your atopic dermatitis, or psoriasis. So these skin conditions here are separate to what I'm talking about when it comes to general dry periocular skin. And I'll talk about those skin conditions a bit further down the line. Now, you do have some patients who talk about having sensitive eyes and sensitive eyelids, and this results from a survey that surveyed people who had sensitive eyes and sensitive eyelids, and looks at their triggers and what kind of causes these symptoms, or they feel causes their symptoms to first come on. And it's quite surprising that you see sun exposure to be so high up. In 87% of those reporting sensitive eyes and 68% of those reporting sensitive eyelids. So sun exposure is pretty critical in a lot of patients' feelings in terms of what they feel exacerbates the sensitivity of the eyes and the sensitivity of their eyelids. Unsurprisingly, things like then dust, dry air, pollens, cosmetics and heat, all of those they feel also do trigger their sensitive eye and sensitive eyelid symptoms as well. If we think about dry skin around the eyelids, I know we all as clinicians see it quite regularly, but we don't always know how to describe it or how to acknowledge it. And some of the key signs that you'll see is dehydration, rough skin, flaky skin, patches of itchy or scaly skin, and maybe even peeling in the skin area. And I think quite often times, we're very, very good at looking at, the lids and the lashes. So for example, this patient here has signs of blepharitis, but we're not really looking much further beyond the overall skin condition itself. So sometimes it's worth just taking an extra moment to take a little step back, drop the magnification just a little bit, and have a look at the overall eye itself and the overall skin condition itself. Because like I said, if they're not maintaining good skin condition in this region, the eyelid is going to struggle to keep moving 16,000 times a day up and down to maintain healthy, adequate blinking. Now, we do have some patients, like I said earlier, who present with symptoms of sensitive skin. Now, the International Forum for the Study of Itch, they define sensitive skin as a syndrome where they get the occurrence of unpleasant sensations in response to stimuli that should not provoke such sensations, and that these sensations are not explained by lesions that are attributable to skin disease. So basically, this is kind of the situation we have where patients present with symptoms but no real signs. And these patients were typically presenting with symptoms, they'll complain of tightness, stinging, burning, dryness, tingling, pain, or even itching for some of these patients. And it's pretty common, actually. This is a survey that looked at a representative sample in 5 different countries. So they looked at Brazil, China, France, Russia, and the USA. And they found over 10,000 respondents take part in this particular survey. And almost 50%, so 48%, reported that they felt they had sensitive skin. They then have another 46% that reported sensitive eyes, and 22 reported sensitive eyelids. And what's really interesting is of that 22%, who asked, if we look at the data a little bit more, 80% of those that had sensitive eyelids also reported sensitive eyes. These are quite large numbers of people. So almost 1 in 5 people reporting sensitive eyelids. And again, this kind of just emphasises some of the facts I shared just a moment ago, where patients are presenting with symptoms and don't necessarily have signs. And this study found that 50% of people who experience sensitive skin don't really have any visible signs of inflammation and dryness. So they would be complaining of burning, stinging and itching, but you can look in the slit lamp and other things, but you're not actually seeing anything highly specific. But what we do know is that the development of sensitive skin is associated with a decrease in ceramides in that layer of the stratum corneum. So like I said, that's that mortar that we talked about at the very start of this presentation. There's a lack of one of the particular types of components within that. And as a result of that, it can lead to the development of these symptoms. And this might be kind of a pre-inflammatory, sort of pre-clinical sort of stage that these patients might be undergoing, and we just can't quite see it yet. So I'm just going to talk a little bit about what is not quite sensitive periocular skin. And basically, we've got quite a few conditions here that we can think about and talk about. And you've probably seen patients come to your practice already with at least one of these in probably the last year or so. And all of these conditions do affect skin integrity, which means that the barrier is compromised in some way. So if we think about things like contact dermatitis, this image here is of a patient who has allergic contact dermatitis, and their causative agent here was shampoo. And if we look closely at the eyelids, we can see that this patient has dry, red, scaly, and they show a sign called lichenification. And lichenification is basically where the eyelids become thickened, and they become thickened because the eyelid is rubbed so much. It just becomes a response that happens by the skin. And oftentimes contact dermatitis in this particular area of the eyes is usually caused by cosmetics. So whether they apply the cosmetics indirectly or directly. And I say indirectly because some common culprits include things like, for this patient, shampoos. It can include conditioners, and then things that you put perhaps closer to this region, so facial cleansers, makeup removers, and even things that you might not think about causing allergen, things like makeup sponges, eyelash curlers, and even things that are applied to the hands that are transferred to the eyes and the eye region can cause an allergic contact dermatitis response. Now, patients who have a history of atopic dermatitis anywhere else in the body, or history of eczema anywhere else in the body, are more prone to developing this sort of reaction. And certainly any colleagues that we have that are dispensing opticians or dispensing very much involved in dispensing are very aware that we have some patients that have nickel allergies, and the transfer of nickel that is in the spectacle frames can get transferred to this immediate eye area as well, and can cause the same reaction. What's probably not an immediate connection with some patients is nail products. So if your patients are going for things like shellac manicures, or if they're having nail extensions with acrylates, that's another real common allergen that is written quite a lot about, and patients don't necessarily associate things that are on their hands causing an immediate eyelid condition. But if you think again about how thin this eyelid region is not surprising that this can happen. If we think about allergic airborne allergic contact dermatitis. So this is a patient that is presenting with allergic airborne contact dermatitis. And what you'll see for this patient is that the reaction is quite specific in allergic response, airborne allergic response. You'll tend to see the upper eyelids, the nasolabial folds of this kind of region either side of the nose. You get it under the chin, you get a response behind the ears, and also along the chest as well. And you'll see kind of that red, irritated, also dry sort of skin as well. So when I say kind of, look at your patients, I really do mean kind of take a step back and sometimes look at them, because it might that this particular response isn't located just to the eyelids, but is more broadly around the face and along the chest as well. Now, what can happen in this condition is that the nose itself is usually spared, so you won't typically get an allergic reaction on the nose itself, and that's what we call a beak sign. But these patients, they do present with quite an extensive response. Some common triggers that usually trigger this include plants. So plants that are from the Compositae, or is also known as the daisy family. Things like chrysanthemum, chamomile, those sorts of things, they, for some patients, can really trigger this airborne response. Various paints, resins, or acrylics can also cause this response. And there are some studies as well where you'll see it as an occupational hazard. So there's some studies where patients work in a pharmacological factory, and certain drugs can cause this response. I don't have an image of irritant contact dermatitis, and that's because in terms of its actual presentation, in terms of what you'll see on the patient, can look really similar to the direct allergic contact dermatitis. The real difference is how your patient presents and kind of what they would describe. So this comes back to you listening to the history. Irritant contact dermatitis tends to come on really quickly, and the discomfort itself is going to be fairly mild, and there'll be a little bit of redness, a little bit of scaling. And that's because, unlike direct allergic contact dermatitis, you don't need a sensitization step, first of all. Okay, so with the allergic contact dermatitis responses, those responses tend to be a bit more slower in terms of onset. They tend to be, in terms of their presentation, a bit more persistent, and sometimes it can be a little bit more severe as well. Okay, so that's probably the biggest difference I can tell you in terms of tips between discerning, is it allergic or is it an irritant contact dermatitis. Okay. We also have patients who sometimes present with atopic dermatitis, and these patients will usually have atopic dermatitis somewhere else in the body. Again, these patients typically present with red skin. There'll be some scaling, swelling of the upper and lower eyelids. And what is quite a classic sign is this Denny-Morgan fold. So this is kind of a double folded skin that you'll see on the lower eyelid. And for some patients, you might even see dark circles under the eyelids because of the congestion of the small blood vessels that can happen in this area. Certainly another common finding that we see for some of our patients here is seborrheic dermatitis. We talked about the skin microbiome earlier. We'll have bacteria and yeasts. One of the yeasts that are present on our skin is the Malassezia yeast. And this yeast tends to live on and around sebaceous glands. And what happens in seborrheic dermatitis is that there's an overpopulation. We just have too much of this yeast. And as a result, we get an inflammatory response. And they don't really know still exactly how this response actually happens. But what you'll see quite often times is the presentation will be isolated in places where we have a lot of sebaceous glands. And that can be at the base of hair follicles. So like our eyebrows, you'll see it quite often. You'll see patients have flakes of skin that is swollen and itchy all around the eyebrows. You might also see them have signs along the scalp, so on the head, in or around the ear. Sometimes with these patients that have it, if at the centre of the chest, they might be able to show you that, and they might have it on the back. Okay, with this sort of condition, because like I said, it's a yeast that is normally present on our skin anyway, it's a case of managing the condition rather than complete eradication. Okay, so you don't tend to cure it, you tend to just have to end up managing it. And then we also have some patients who present with psoriasis on the eyelids. In terms of eyelid psoriasis, overall compared to psoriasis in other parts of the body, it is more rare, but it can happen. So it's here for inclusion because it does happen for some of our patients, although it is far less common as a site of reaction compared to other parts of our body. For these patients with psoriasis, what effectively happens is the skin cell turnover is much too fast. And because it's too fast, what you get is you get accumulation of those corneocytes, those dead skin cells. They cluster together, they clump together, and then you get this development of plaques, white plaques that are left on the skin. And the skin itself is quite red, quite irritated, quite tender, quite sore. And again, that's kind of something that is going to have to be managed by you manage the condition itself. But you'll often find that they have psoriasis on other parts of their body, and the eye is just another site that unfortunately does, for some patients, get affected. Ultimately, in all of these conditions that I've described here, they're going to have a change in skin barrier function. So quite important to bear that in mind. The skin's going to be really quite inflamed, quite tender. It's going to be more dry and irritated overall. And in terms of managing these patients that present with different types of dermatitis, you really want to keep the skincare regimen simple for these patients. So, they're not going to be using things like eye cosmetics. They're probably not going to want to use it anyway, but you're going to tell them to keep it really simple. So we really come down to cleansing, moisturizing, treating the cause as well. And when I talk about treating the cause, it's really, targeting your treatment according to what's causing the condition. So for example, for your allergic cases, you might be eliminating the cause. So if, for example, a patient has used a shampoo and they know it's a shampoo that's causing it, they're going to stop using that particular shampoo. For some patients, it might take a long time for them to work out exactly what it is that's a causative agent, and sometimes in some products, the same trigger ingredient for them might be present in lots of other similar products. So for some patients, you're going to refer to dermatology for patch testing to really determine what their triggering factor might be. When you talk about treating the cause, like I said, for your seborrheic dermatitis patients, you're going to be using something like an antifungal. So whether it's a ketoconazole shampoo or miconazole cream, because you need to target the yeast population for those particular patients, okay? These patients, we tend to recommend that they use a simple emollient. Emollients basically protect skin integrity. Okay, so they help to restore the barrier function of the skin, and as a result of that, they can be quite soothing for some patients to put onto their skin by reducing the itching. They can increase the level of hydration as well, so it really kind of help and support the barrier as much as we can when it's disrupted in that way. And there are some studies that show that by using an emollient, it can help regenerate the skin barrier as well when it's been disrupted. For some of our patients with the airborne allergic cases, an extra emollient also helps slow down the penetration of the antigen that's causing this inflammatory response. So it can be really helpful in terms of stopping things from getting in any deeper than it already is. For some different types of emollients, they can be used as a soap substitute. So what I mean by that is they can apply it, use it as a cleanser, gently remove any excess and then leave it, so you don't have to rinse it off. So it's more of a leave on treatment. So for those whose skin is really triggered by even water, it can be really helpful and quite soothing for those patients. And it's really important for patients with atopic dermatitis, particularly, that they still need to use it every day, even when the skin seems okay. All right, because this will kind of just maintain that healthy barrier for an eye for skin that is quite already prone to compromise and a reduction in integrity. From a pharmaceutical perspective, if you can prescribe pharmaceutical agents, really there's two main categories of treatments that typically get used in and around this area for these sorts of conditions. It's either going to be a topical corticosteroid or a topical calcineurin inhibitor. And the difference between the use of these two is how long are you planning to use that agent for this patient. So your topical corticosteroids, you're thinking of using or recommending this for your patients or prescribing for your patients if it's going to be just a short course or a few days. So this will be kind of like your sudden onset of a condition that's a bit of a flare. You might use it for a few days and then stop there. The reason for this being a short-term use is because, as you're probably very much aware, corticosteroids can have some nasty side effects. So elevation of IOP, development of cataract, and more worrying as well in terms of a skin perspective is thinning of the skin as well. Now, you can use topical calcineurin inhibitors as your non-steroidal approach, and you can use them much more longer term with far fewer complications. Here in the UK, we have access to two. We have Protopic and Illidel. These are highly effective. The one thing I'll probably say is for those patients that you might be using the Protopic or the tacrolimus drug for the first time, is a warning to the patients that when they first apply it, it can feel like it burns. So just let them know that it's going to burn a little bit when you first put it on, but that does subside and it's not a prolonged thing. So don't panic. I think it's worth telling those patients or just kind of counseling those patients ahead of time. In terms of managing dermatitis, like I said, you can use emollients in conjunction with some of the pharmaceutical agents that we've talked about. And really, we don't know which order. There's not good advice in terms of which order of treatments should be used. There's arguments for using emollients first or using the topical drug first. And certainly here in the UK, we have the NICE guidelines, which looks at the evaluation of a lot of the evidence in terms of being able to provide good clinical advice. They advise that patients should just do what they feel is best for them. So really, we don't know. But in terms of if you think about the argument for emollient first, the argument for this step is that it may help the drug absorb better into the skin. And as a result, you get a better, more effective, targeted treatment. The argument for using the drug first is that you're getting the drug directly to the area that needs it. But because you still need to put an emollient on top, there is a small risk as well that you're going to be moving the steroid onto other parts of the skin that doesn't need it. So there's just some concerns there. What dermatologists do typically recommend is that you allow about 20 minutes between each of those products that you're applying to the skin. So allow 20 minutes between whether it's topical first or emollient first. Just allow a little bit of time to allow the product to seep in, work, and then apply the other one on top. So what if you don't have a patient that got dermatitis? How should patients just be managing healthy skin around the eyes anyway? And these are three fundamental steps that dermatologists talk about quite a lot that are highly applicable for us as eye care practitioners to recommend to our patients. Because like I said earlier, maintaining healthy skin means we have better lid function and overall better function of the eye area. So these three functions include cleansing the skin, moisturizing the skin, and then sun protection as well. When it comes to cleansing the skin, I get asked a lot of the time by my patients, what should I use? Do I need to use just water? Do I need to use a cleansing product? Do I need a muslin cloth, a cloth, or a specific cleansing device? And really it depends. There's no easy answer. It really does depend on your patient. If you come in from a bike ride and you're all horribly mucky and muddy, you might need all of those things. You might need your cloth or cleansing device and your water and your cleansing agent. But day to day, for most patients, a simple cleanser is going to be perfectly sufficient. They might want to use a cloth for some patients. Just be mindful that for some patients with sensitive, delicate skin, that cloth can act like a physical exfoliant, and that for some patients with quite sensitive skin can cause more sensitization in the eye area. However, if you've got patients who have a lot of cosmetics on, for example, a cloth is something that they might need to use to help take off any excess. Effectively, what is in a cleanser is surfactants, and these are the things that really make a cleanser work well. You have a hydrophilic head and a hydrophobic tail, and the hydrophobic tail is attached to the dirt, and the hydrophilic heads enables it to disperse in water and then rinse off the dirt. So a cleanser, it can be highly effective agent for a lot of our patients. But the concerns with some cleansers, though, is the pH of them. Skin itself is naturally acidic. And unfortunately, a lot of cleansers can be high pH, so quite the opposite of acidic. And unfortunately, for some patients, using a high pH cleanser can affect the structure of the skin. It can increase swelling of the stratum corneum, and this can allow the detergent to get deeper into the skin and ends up becoming a more sensitizing agent. If you couple this with any pre-existing irritation or itching, redness, dryness, it can make the skin feel worse in the long term. And there are products such as synthetic detergents, which means that the pH can come down to a much lower skin-like level, or even kind of be more pH neutral at pH 7. And this is a really nice paper that is worth having a little look at in terms of going through the different types of cleansing agents that are available and the different pHs that they're available in. And as a result of that, how does that impact the skin and the skin barrier itself? Typically, we recommend our patients to use a gentle facial cleanser. What I mean by that is it doesn't have to be full of bells and whistles. And for some patients, and probably I'd argue most of our patients, they probably only need to use the cleanser in the evening to take off the day's dirt. Usually if they've cleansed in the evening with the cleanser, they're unlikely to need it again in the morning because there's not a lot of stuff getting on your face overnight. The dermatologist would always say to the patients, select according to your skin type and what your skin needs are. What this often means that for some of our perhaps teenagers or some of our acne-prone patients might prefer to use a cleanser that has some chemical exfoliants, such as salicylic acid. And unfortunately, that can have some knock-on effects onto the ocular surface if that gets into the eye. So for some patients that are perhaps on some acne treatments, you might be asking them to really be careful when they're washing their face. So kind of making sure that they're not getting that cleanser onto the eyelids and onto the skin underneath the eyes as well, and keeping it away. And they're the people that might find using a cleansing cloth to be quite useful in terms of getting the drips away from the eye region. There are some gentle cleansers that have a lot of humectants in it, things like glycerin. And what that means, if you have a patient who is more prone to dry skin or dehydrated skin to begin with, this can really help mitigate some of the dryness that they're going to get after using the cleanser on the skin. I've put fragrance-free here, and this applies to both cleansing and moisturising as well, but I'll just talk about it here as kind of the first product we're talking about. Now, fragrances can be quite controversial. A lot of people enjoy fragrances as part of their skincare products because it just makes the experience of using it a much more pleasurable experience. My other half says a funny thing sometimes. He says sometimes he doesn't like using some of the skin products that don't have a fragrance because it reminds him of a really dull old smell. I don't really know what he means by that, but that's what he says. For some patients, though, who already have prior skin sensitization, some fragrances have the potential to make it worse, particularly if there's a lot of fragrance in the product. And therefore, for some patients, it can induce contact dermatitis. So sometimes fragrance-free is probably the easier option for some patients that have kind of dry, disrupted skin barriers already. In terms of our makeup users, I said earlier they might need an additional product to remove some of the eye cosmetics first. I can talk about makeup removing for a very, very long time. It's something that is quite close to my heart, but I'm not going to talk about it there. What I'm saying is they might need an additional step to help take that off before they go in and rinse all of that stuff off with a cleanser. I've put wipes on here, including lid hygiene as well. And that's because if you are a practitioner that is recommending eyelid hygiene in the form of eyelid wipes, and this also can apply to some of the facial wipes that exist on the market, double check and be familiar with the instructions of use. Some of them will explicitly say that they need to be rinsed off after use. Okay, so really being sure that you are telling your patient to do the right thing. And that's because some of these wipes have quite heavy surfactants on them that if they're left on the skin for too long, you can end up, for some patients, getting an allergic contact dermatitis response in the long run. So just make sure that you are advising your patients appropriately and be familiar with the products that you are recommending to your patients. I'm going to talk a little bit about water, and I'm not going to talk about this for too long, but it's something that, again, is quite topical. 60% of households here in the UK live in a hard water area, and that means that's about 13 million households in total. And this will very much depend on where you are in the world, and even within your country, you might have hotspots of hard water and soft water. What I mean by hard water is it is water that has more dissolved calcium and magnesium carbonates. You probably know this if you live in a hard water area, that if you try and put some soap on your hands and you try and rub it to generate a lather, you're not seeing much foaming or bubbling. So that's one of the signs that you might know that you live in a hard water area. There are other signs as well. But effectively, those who live in a hard water area will find that there's more or increased deposit of surfactant left on the skin. And as a result of that kind of negative effect, we tend to see that these patients have increased transepidermal water loss. So remember, that's a bad. If the higher the transepidermal water loss is poor, and as a result, that leads to more irritation. We know already as well that living in a hard water area also increases the risk of contact dermatitis. So for some parts of the world, water softening at home is going to be really critical in kind of maintaining what comes out of your taps to be soft and suitable in minimising the reactions on the skin. And I've got a bit of a personal relationship with this kind of thing. I grew up in Wales here, and also spent a lot of time living in the southwest of England as well. So I've only ever lived in soft water areas. But I moved to Canada about 10 years ago and was living in Waterloo. And that area has exceptionally hard water, and what you'll find is that I found my skin to be really irritated. My skin would be prone to cracking, and that wasn't just on my face or my arms or my legs, even my feet. The tough parts of the body can get affected as well. So just something just to bear in mind with depending on which part of the world you live in, or if you live in a hard water area and patients move into your area and they start complaining of changes, you might know why. I'm going to talk about moisturising a little bit here as well. Moisturising itself has three main types of ingredients. We have the humectants, which are water grabbers, and effectively humectants just basically help the stratum corneum absorb water and attract water rather from the dermis, so underneath the epidermis, or from the humid environment and getting that into the epidermis. We also have emollients as well. These are usually lipids, but quite oftentimes they're also not lipids as well. And these emollients really fill in any of the gaps that you have between the corneocytes and boosting skin hydration, smoothness, flexibility of the skin. And then we have occlusives as well, and occlusives really help form a hydrophobic barrier over the skin, and it blocks any evaporation of water away from the skin's surface. So really what we're doing with moisturising is improving the skin barrier, the function, and boosting the hydration of the skin area to maintain that pliable skin that we really want. And a lot of times patients will ask me as well, do I need an eye-specific moisturiser? And again, this is kind of one of those things that is not always easy to answer. It really does depend on every patient. I tend to find that if patients are already telling me they've got sensitive eyes, then I'd be more prone to saying yes. Also, if they are showing signs of skin redness, dryness, flakiness, or scaling again, I'd also say yes. For some patients, though, they might already use a facial moisturiser and get that up and around the eyes. Something to bear in mind is that the formulation that you find for facial moisturisers might be a bit too much for the eyelids. And also what you might find as well is in terms of recommending a moisturiser for use around the eyes really depends on the season. It's a bit like if you think about clothing, if you might have a summer jacket and then you might have a winter jacket, and what you need in the winter is not quite what you need in the summer, and vice versa. You get some patients who are really happy to use an eye moisturiser because they have specific concerns. So they might have concerns in terms of an aging perspective or a dark circles perspective. So they'll be looking for products that contain retinoids, caffeines, or hyaluronic acid. And those are absolutely fine for some patients. Just bear in mind that some of those products can get into the eyes and that can cause sting for some patients. So the eyes can start to sting in water and feel quite uncomfortable. And certainly if you have patients who are showing signs of any of the dermatitis that I showed in earlier slides, so things like allergic conjunctivitis or disrupted skin barrier, I tend to tell them stay away from those products that have active ingredients. Keep it really, really simple. The reason why some of the skin face moisturizers might not be suitable for the eyelids is because it might contain more of an occlusive. So what I talked about earlier in the moisturizing slide here are those 3 different types of main ingredients. What you'll find is that patients don't go shopping for 3 separate products that does each of these things. A jar of moisturizer or a bottle of moisturizer will typically have ingredients in it which do each of these 3 functions. What sometimes happens is for some facial moisturizers, it may contain too much of an occlusive element in it. And what that can end up causing are these things called milia, which you might see on some patients, these small little yellowy white kind of bumps that are just under the skin. And it's basically balls of trapped keratin. And that can be a sign that the moisturizer is a bit too thick. And the patient should really probably consider using a lighter, thinner moisturizing for the eye area. I talked about migration of these products into the eyes may cause stinging, so it's just something to be aware of. But for those with atopic dermatitis, the eczema prone amongst us, quite oftentimes ophthalmologists, dermatologists will say, your eye ointment that you use, and you can pop a little bit of that around any cracked or sore bits, and it does work really, really well. Because these ointments typically have things like petroleum jelly, liquid paraffin, those occlusives that you really want to kind of seal in and reduce transepidermal water loss. One thing just to bear in mind though are things like lanolin. Lanolin is one ingredient for those who already have a disrupted barrier, poses them at a slightly higher risk for an allergic contact dermatitis response. In 2023, the American Contact Dermatitis Society named lanolin as the allergen of the year. They do this every year with different ingredients, but it is something just to make sure that we're aware of when we're talking to our patients. Last of all, on my top list of 3 tips for maintaining healthy periocular skin is sun protection. We know that UV radiation is the most common cause of premature skin aging, and if that isn't something that worries you, it's okay. It's not always a vanity thing. I think the other thing important thing to remember is skin cancer is highly prevalent on the head and neck compared to the rest of the body. And here are some images of some basal cell carcinomas that you see. And the most common site for basal cell carcinomas typically is the lower lids, followed by the medial canthus, and lastly the upper lids. So what I recommend for my patients when it comes to sun protection is what I call what is called the Swiss cheese model that they use quite a lot in risk analysis and risk management. And you might have come across this during the COVID-19 pandemic when we were all told it's not just vaccinations that are going to help slow down or prevent the spread of COVID-19. It's things like wearing a mask, being in good ventilated areas, and vaccinations. So it's the same thing in terms of protecting yourself from skin cancer. This is marketing that you're probably seeing globally. This one is specifically from Australia. But effectively what we're telling patients to do is slip on a top, slop on some sunscreen, slap on a hat, seek the shade, and slide on some sunglasses. So really for us as eye care practitioners, we'd be telling our patients to do probably the latter 4 things. So popping on the sunscreen, the hat, the shade, and also the sunglasses. I often get asked quite a lot, particularly by men, can I use a combination product? So can I have a product that does more than one thing? And quite oftentimes they'll ask me, is a moisturizer with SPF okay? And oftentimes, yes, it is, because for them, using some form of SPF is better than not using anything at all. The only downside to this is that there's some studies that show that if your patients are using an SPF moisturizer, it does increase their risk of skin cancer because they're missing out the application of certain areas. And this is the study that was reported that. So they compared the application of sunscreen versus an SPF moisturizer. And what they did is they had the patients apply these products and took photographs of them under a UV camera. So this is the UV sensitive camera compared to a normal camera, and this is the UV camera with sunscreen on, an image there, and and then an image of with the UV camera with just the SPF moisturizers. And what they found was that the application of moisturizer SPF was significantly worse than sunscreen because patients missed more areas. And what was the area that was missed the most was the eyelids. and the eyelid regions, particularly in the area of the medial canthus, was particularly affected. So really, this is why I talk about the Swiss cheese model and why it's really important that your patients do more than one thing in terms of skin protection. Sunglasses, a hat, and shade are going to be critical in terms of maintaining skin integrity and reducing the risk of skin cancers. And I mean, yes, it's very good that we can remove these BCCs and SCCs in the long run, but some of these can have devastating effects in terms of eyelid integrity and ultimately eyelid function. So what are the take-home messages? I'm very aware of the time. Just remember that 50% of our patients with sensitive skin might not show signs of irritation. We're going to tell our patients to choose and use their skin cleansing products carefully and tell our patients to cleanse regularly, but not too much. Sometimes our patients' barriers get disrupted because they've purely just cleansed too much or they rub too much with the particular product. Hydrated skin is soft skin, which is healthy skin, and that's really important to remember. Moisturising is only one part of maintaining a healthy skin barrier. And then most important thing that I just talked about a moment ago is also sun protection. And, you know, here in the Northern Hemisphere, it is our summer, so it's front of mind for us here. But I think it's really important that sun protection all year round is absolutely critical. So with that, I just want to say thank you very much. Sorry about the time. Yeah, I'm happy to take any questions if anybody has anything.
Well, thank you, Dr. Alison, for that wonderful presentation. I think this is something which is a bit very common these days and I saw you link a lot of it to dry eye disease and skin and things like that. But often we tend to ignore a lot of things in terms of how we're going to explain. Thank you for sharing those little tips, you know. If we see this, we must be telling them to use this and we must be telling them to cleanse like this, and you know, a lot of advices on what should be the product or what should the product contain when they want to do those cleansing. So thank you so much for sharing those thoughts with us today.
My pleasure.
So one question has just popped in, I guess, and I think this is again something which is very common. Would you have any advice for patients who have these dark circles around? You know, this is, I think, becoming very common, probably with the lifestyle which we are in. But any advice on this particular aspect you have today?
That is a really great question, and it depends on the cause. It's going to be a really boring answer, but it really does depend on what's caused it. So for some patients, the dark circles is just purely because we get loss of volume around the eyelids. So really, it's a shadow. So it's not because there's actual dark skin, but it's more because we've lost volume. And this happens more as we get older as well. We lose that volume, and as a result, the skin gets a bit more sunken in, and it causes more of an appearance of dark circles. We also get some patients who do have dark circles because there's just a bit more congestion of the blood vessels around that area. I'm not an esthetician, so I'm not going to be best placed to advise on in terms of what I tell patients to do in terms of getting rid of the dark circles around the eyes. I don't think dark circles is necessarily harmful. I think that's one really important thing to remind your patients. It's not a harmful thing to have a dark circles around your eyes. Certainly from an aesthetics perspective, some patients obviously don't like the look of dark circles. And I know there's certain products out there, you know, we talk about things like caffeine. So a lot of the eyecare products that, this eye creams that you can get contain active ingredients like caffeine that, you know, claim to kind of brighten the eyes and kind of lift the eyes. But certainly I would say have a little closer look at some of the products that if you are going to be recommending to patients, have a look at what's in those ingredients first, because for some patients, if they are applying it on or around their eyes, it could increase the sensitization of the eyelid skin, but also it can also cause a bit more sting to the eyes. So if they're a patient who, for example, has, you know, dry eye disease, I'm not going to be quick to recommend an eye cream that might have an active ingredient in it, only because it can cause a bit more sting for those patients. But certainly I would say have a look at what's causing your patient's dark circles to begin with. And then, you know, go from there really, because for some patients it might not be a skin thing, it might just be a loss of volume thing.
Yeah. And I think that's really an important message on, informing the patients that they might not really have to worry about it. It's something which you have to probably
Mm,
monitor over time and see if it's getting worse, and then we might put into clinical decision making. Some of them are really concerned, is it affecting the eye or something like that? So I
mm.
think giving that reassurance and letting them know that we are aware, but we'll take it at step by step, right? Yeah.
Yeah, and I think as well, it depends because some patients, for example, those who have a history of atopic dermatitis, so those who have got, I used a word earlier called lichenification, where basically if a patient rubs their eyes an awful lot, they get that thickened skin, and sometimes that can be prone to hyperpigmentation as well. So I think it's really, if a patient presents with a disrupted barrier in some ways, it's kind of getting on top of that, reducing the inflammation, so they're not going to have some of those knock-on side effects further down the line. So again, it really comes down to this preventative approach of kind of things, stopping
Yeah.
things from getting worse, really. Yeah.
Yeah. And any advice on the other spectrum? I think if you have patients who have baggy eyes or fluffy eyes around, any advice do you think would be suitable?
Oh, do you know what?
Products? Yeah.
I said this to somebody last week. I used the words, it's a privilege to age. I think, as much as the baggage, no pun intended, baggage that comes with age, I think it's a real privilege to be able to grow older. And unfortunately, things like eye bags and puffiness around the eyes is associated with age. We get a lot of changes in that area. The safest thing that we can recommend for our patients is something like a cool compress. So cool compresses regularly, that's kind of your best pharmaceutical, non-pharmaceutical, non-pharmacological approach to kind of reducing the eye bags and puffiness around the eyes. Again, have a look at what's the cause as well. So if it's somebody has puffiness because they have an allergic response to something, manage that. Again, for a lot of patients, pollutions, irritants in the air, again, this might be a seasonal thing as well. They might get flares of it every now and then. So they'll go through a couple of good months and then have a couple of bad months. Eradicating the allergic cause is really, really crucial to that. But if we're talking about general puffiness that comes with age, and I'm so sorry, there's nothing that I would probably recommend in terms of that has good, solid clinical evidence that is highly effective in reducing puffiness. But cool compress can work wonders. And like I said, getting to the source of the cause, if there is one, like I said, an allergic response is really crucial.
Yeah, that's true. And just taking one more question here, I think this is again something quite common, probably,
Mm,
which we see in this part of the world. People who
mm,
have association of dry scalp and having dandruff and flakes, they do have a little bit of dryness around their, the periorbital region as well.
mhm.
Any advice? Would you want to recommend
Yeah.
in terms of what they should do to maintain and make it better? Yeah.
Yeah, so for these sorts of patients, it sounds like it could be your presentation of seborrheic dermatitis. So for that, I think I spoke about this earlier. You're getting this overproduction of yeasts around the skin, and it happens. It sounds like because this patient is, or your patients are getting them on the scalp, around the ears and inside the ears, where there are lots of hair follicles. And what happens with seborrheic dermatitis is these yeasts tend to prefer the sebaceous gland areas, which is where a lot of hair follicles are based. So typically, if you're seeing this, a medicated shampoo, so with ketoconazole, or for some areas of the body as well, you can use a miconazole ointment. And these are antifungal topicals that can be used on the affected areas to manage that. And what that will do is reduce the overpopulation of yeast, and then really get to the root of the problem. Now, because it's caused by yeast that are normally on the skin anyway, what you'll find is that some patients will have phases with this. So you'll eradicate it at first, perhaps with the shampoo and the ointment, and they'll have a couple of good weeks or a couple of good months, and then it can come back and flare up again. And that's just because you get this overpopulation that happens again. So sometimes for these patients, it's kind of keeping on top of it, whether it's kind of using that pharmacological treatment kind of once a week, just to kind of maintain the levels of yeast. They don't have to do it every day, but kind of like once a week, once every 2 weeks might be enough to kind of just keep the yeast levels on kind of a normal lower population, to minimize some of these signs that they're getting. But it can be really uncomfortable as well. Apart from kind of that flakiness, skin can be quite red and quite inflamed. Some of these patients might need a bit of a steroid to kind of keep that skin side under control. So a short course, a couple of days of that, just to kind of keep things down and quiet, might be really helpful for these patients. But it's about kind of long term, kind of keeping on top of that yeast population.
Yeah, yeah, right. I think the most important thing is when you see this, giving proper advice, and if necessary, I think we should always think about referring them to a proper skin specialist, right? I mean,
Absolutely.
dermatologist and things like that, so that you're able to help them. Because,
Yeah.
yeah, as you say, sometimes all of these surrounding skin area might aggravate the condition around the eyes, and that
Yeah.
might aggravate the ocular regions as well,
Exactly,
right? Yeah.
exactly. I mean, it's at the end of the day, skin is this one continuum, right? There's not from top to bottom. There's it's one big continuum.
Yeah.
So it's really important to kind of think about what we do in one part of our body, particularly if it's on the head. It'll start to affect the eyes and so and so on and so forth. So it's if at any point you feel outside of your comfort, and within your competence as an eye care practitioner, referred to, whether it's the family doctor or a dermatologist or an ophthalmologist, and referred to the next other clinician that can
Specialist,
really
yeah.
help support the
Right.
care.
Yeah.
Yeah.
Yeah. Wonderful. Great. So I think with that, taken most of the questions. Thank you so much,
Thank
Dr.
you.
Alison, once again for sharing those wonderful thoughts with us today. And I think, once we get into the practice, most of them can be directly applied when we see such patients. So I hope that, all of us can take good messages and key take points and start treating our patients and making our patients' life better. So thank you so much for sharing those
My
thoughts with us.
It's my absolute pleasure. Thank you very much again for the invitation, and enjoy looking at the skin and looking at the eyes.
Right, understood. Yeah.
All right.
Thank you so much, everybody, for attending. And we do have session planned in the next month, and we'll keep informed about the session details onto your emails and the social media. Until then, take care, be safe, and I hope to see you during the next session. Take care and have a good day. Bye bye. Bye. Thank you, Dr. Alison. Bye.